Welcome to E3 Rehab. I'm Dr. Mark Sertica, physical therapist. Today, I'm going to discuss a condition that goes by many names: hip bursitis, trochanteric bursitis, greater trochanteric pain syndrome, gluteal tendinopathy, and the list goes on. I'm going to outline which of these diagnoses is most accurate based on the research, and then use that information to show you activity modifications and exercise progressions that you can do to help manage your symptoms. Let's start by describing the anatomy of this region. On the outside aspect of your hip, you have a bony prominence known as the greater trochanter. It is part of the femur, or thigh bone, and serves as an attachment site for various muscles, including the gluteus medius and minimus. These two muscles primarily act to abduct your hip in a non-weight-bearing position, or, more importantly, stabilize the pelvis in a weight-bearing position. Superficial to these tissues, or closer to the skin, lies the iliotibial band that runs from the pelvis all the way down to the knee, with the tensor fasciae lata attaching to it from the front, and part of the gluteus maximus attaching to it from the back. Finally, you have several bursa here, which are small, fluid-filled sacs that help to cushion and reduce friction in the area. Understanding the anatomy is an integral component of defining the diagnosis and outlining the appropriate framework for rehabilitation, because many individuals associate symptoms here with the word bursitis based on what they've heard or read. The suffix itis implies inflammation of a bursa, the subgluteus maximus bursa to be exact, which then often dictates treatment, because inflammation is usually addressed with rest, ice, and anti-inflammatories. However, hip bursitis and trochanteric bursitis are not the most appropriate terms to describe this lateral hip pain. In 2001, Bird et al. Performed MRI examination of 24 symptomatic patients and only found bursal distension or enlargement in 8% of cases, and it wasn't an independent finding, meaning that it was always associated with gluteus medius pathology, which was discovered in 83% of cases. In 2003, Connell and colleagues found that 53 of the 75 patients in their study showed sonographic evidence of gluteus medius tendinopathy. In 2008, Woodley et al. Found that tendon pathology was more common in symptomatic hips, while bursitis was actually equally prevalent in symptomatic and asymptomatic hips within the same group of participants. In another study in 2008 titled Trochanteric Bursitis: Refuting the Myth of Inflammation by Silva and colleagues, the researchers removed the subgluteus maximus bursa in 5 patients undergoing total hip replacements and reported that histological analysis showed no evidence of inflammation in the individuals diagnosed with trochanteric bursitis. In 2010, Fearon et al. Retrospectively compared preoperative ultrasound imaging with surgical and histopathological findings in 24 patients who had combined gluteal tendon reconstruction and bursectomy, and concluded that there was no evidence of ongoing acute bursitis. Therefore, they believed treatment should address the gluteal tendinopathy as a primary goal. Finally, Long et al. In 2013 retrospectively reviewed musculoskeletal sonographic examinations performed at their institution over a 6-year period for greater trochanteric pain syndrome, and found that 80% of patients did not have bursitis on ultrasound. They concluded that the cause of greater trochanteric pain syndrome is usually some combination of pathology involving the gluteus medius and gluteus minimus tendons, as well as the iliotibial band. So what do we do with all of this information? Well, it's not to say that inflammation is never present or never a possible contributing factor, but it doesn't seem to be the primary driver of symptoms, so we probably shouldn't be using the term hip bursitis. The reason that this is so important is that it helps shift your mindset and guides treatment. For example, as I alluded to earlier, if you assume that your symptoms are due to inflammation, you might take a very passive approach: rest, ice, and medication. It almost puts you in the back seat. But if you treat it more like a tendinopathy, managing load to the area as needed, then you're in control. You're in the driver's seat, and you can start taking the appropriate steps to helping yourself. The last thing to note before moving on to the last 2 sections is that there are multiple reasons why people might have symptoms in this region that are beyond the scope of this video. However, Grimaldi 2016 and Ganderton 2017 found that pain with standing on one leg for 30 seconds or resisted hip abduction can help rule in this condition, and no pain with palpation of the greater trochanter can help rule out this condition. Activity modifications are a key component of rehabilitation for this lateral hip pain, as outlined by Grimaldi and Fearon and Grimaldi et al. In 2015. These recommendations are based on trying to reduce compression of the gluteal tendons at their attachment site on the greater trochanter, either directly, such as by lying on that side, or via the overlying IT band when the hip is in adduction, as demonstrated by Birnbaum and colleagues in 2004. Let's rattle off some possible activities to modify, but also understand that if they don't cause you any issues, don't worry about them. Sleeping. Minimize sleeping on the affected side, and keep a pillow or two between your legs when sleeping on the unaffected side. Sitting. Limit sitting cross-legged or in deep hip flexion for extended periods of time. Stretching. Temporarily avoid the so-called piriformis and IT band stretches, as they might contribute to symptoms. Standing. Reduce time spent, quote-unquote, hanging on one leg. Walking. Track your steps to determine your tolerable baseline and then build up over time. Stairs. Use the handrail on the opposite side of your affected hip to offload those tendons as needed. And running. Increasing cadence by 5 to 10% can help reduce hip adduction. So those are all considerations for ways to potentially reduce the amount of load experienced by the gluteal tendons, but we also want to introduce load over time to help build up their capacity, and that's where these exercise progressions come into play. With regards to changes in function, Allison and colleagues dominate the research here. Individuals with gluteal tendinopathy demonstrate weakness of their hip abductors bilaterally and alterations in muscle activity and mechanics during gait, so the focus of rehabilitation will be twofold: strengthen the hip abductors and eventually progress to single-leg weight-bearing exercises. Honestly, it doesn't actually matter how you accomplish these tasks, as long as the exercises are appropriately challenging and tolerable. You're objectively making progress on a week-to-week or month-to-month basis, and you're giving yourself at least 3 months of a dedicated regimen. Otherwise, don't get too caught up in the minutia. So isometrics are one possible starting point. I'm going to show you 3 different tiers of exercises: easy, medium, and hard, and you really only need to pick 1 or 2 exercises based on your symptoms and strength, and then you can regress or progress as needed. 3 to 5 sets of 10 to 60 seconds at the highest comfortable intensity, daily or every other day. 2 options for easy: standing with your feet a little more than hip width apart and thinking about spreading the floor beneath you without actually moving your legs. And 2, lying on your back, pillow under your knees with a belt or band just above your knees while trying to spread that belt or band outward. 2 options for medium: 1, a short side plank on your forearm and knees with the body in a nice straight line, and 2, sideline hip abductions with your legs slightly behind the plane of your body, leg rotated inward, and held slightly above parallel with the floor. 2 options for hard: 1, a regular side plank on your forearm and feet, and 2, that same sideline hip abduction, only this time with a band around both knees to increase the difficulty. Isotonics are another possible starting point, and I'm a big fan of side steps. Without a band is easier, with a band around the knees is medium, and a band around the ankles is hardest. You can vary the width of your step and resistance of the band to accommodate your needs. You can also see how this could be progressed from the standing isometric. And as I mentioned, you want to eventually perform some type of single leg exercise. You can start with squats, deadlifts, and bridges, and then progress to their single leg variants. Or you can start with single leg balance and work your way up to step ups, step downs, reaches, standing fire hydrants, and the list goes on. Okay, quick summary. Gluteal tendinopathy, greater trochanteric pain syndrome, and lateral hip pain are more appropriate terms to describe these symptoms, since inflammation of the bursa doesn't seem to be the driving factor here. Monitor and modify aggravating activities such as sleeping, sitting, and stretching, and strengthen your hip musculature, particularly your hip abductors, and eventually include challenging single leg exercises. Thank you so much for watching. If you enjoyed the video, please hit that like button, subscribe. You can also head over to our website, e3rehab.com, where you can find the blog with all of the references, and we actually have a ton of programs that address every single body part. Peace.